So, welcome to this Facebook Live event organized by ANMS. Today we're going to talk about management of IBS. My name is Magnus Simron. I'm working in Gothenburg, Sweden. I'm a gastroenterologist and I will do a presentation with slides during this live event. We will also have a Q&A session after the presentation. Some of you have submitted questions in advance, but you can also submit questions during the session. And the Q&A session will be managed by Stephanie Twist from ANMS, who will ask your questions to me, and I will try to respond to them as good as I can. As I said, my name is Magnus Simron. I work in Gothenburg in Sweden, but I'm also an adjunct professor at UNC here in the US, and currently I'm actually in the US, but I brought my Swedish cup with me so I don't feel homesick too much. So I will have a sip of coffee every now and then during this presentation from my Swedish cup. Now I think it's time to move on to the presentation. There will be some slides that you will see appear hopefully on the screen when you listen to the presentation. So as I said, the presentation is about management of IBS, and I will give you a brief outline before I start. The first couple of slides are about the general features, the background information about IBS and so forth, and then we will move on and discuss the management approach, both when it comes to how to make a safe diagnosis of IBS, also about treatment options and general management principles. So this is a figure demonstrating the spectrum of functional bowel disorders, how we define them today. IBS is one of the functional bowel disorders, but not the only functional bowel disorder. We consider these disorders as being a spectrum of disorders today. They are characterized by various combinations of abnormal bowel habits and different degrees of pain and bloating and distension. So this is how we define these disorders. As you will see on the coming slides, IBS is characterized by a combination of pain and abnormal bowel habits. But we also have other functional bowel disorders such as functional constipation and functional diarrhea, where you can see on this slide there is not so much pain, but more of the abnormal bowel habit that dominates in these patients. And you also have the group that is called functional bloating or functional abdominal distension, where the bloating and the abdominal distension predominates over the other symptoms. But we also know that many of these symptoms come and go a little bit in individual patients. So if for a certain patient, you can actually move in and out of these categories a little bit. So at some time point, you will have more pain and with your constipation, and then you are categorized as IBS with constipation. But another time you may not have so much pain, but more predominantly constipation symptoms, and then your doctor may characterize you as functional constipation. And this is something that we have seen from several investigations, that the symptom pattern varies over time in the individual patients. So let's move on to IBS. These are the diagnostic criteria for IBS. Since all of these disorders are characterized, as I said, by combination of different symptoms, we don't have any what we call biomarkers. We cannot do a specific test to make this diagnosis. The diagnosis is made based on combination of symptoms. And here you have the diagnostic criteria for IBS from the latest edition of the diagnostic criteria called the Rome 4 criteria. So if you have IBS, you should have recurrent abdominal pain on average at least 1 day per week in the last 3 months, associated with 2 or more of the following criteria. It should be related to defecation and or associated with change in the frequency of stool and or associated with change in the form or appearance of stool. And as you see here, these symptoms should be active, that is, they should be present in the last 3 months. There should also be some chronicity, so the symptom onset should have been at least 6 months prior to the diagnosis. So patients who have abdominal pain only for 1 day does not fulfill the criteria for IBS, but there should be some chronicity, current symptom, and as you see here, an association between abdominal pain and abnormal bowel habits, and there should be some relation to defecation. So this is actually how you make the diagnosis that patients fulfill the Rome 4 criteria. This is not sufficient. I will come back to that a little bit later when it comes to how to make a diagnosis. You also need to rule out some other diagnosis with reasonable certainty. But in the majority of patients with IBS, the number of tests that are needed can be very, very limited, and only a few tests are needed. So patients with IBS and other functional gastrointestinal disorders, they do not only have the symptoms that fulfill that particular diagnosis, but there is also a huge overlap among these different functional gastrointestinal disorders. So many patients with bowel symptoms also have symptoms in the upper part of the GI tract, for instance, gastroduodenal symptoms, esophageal symptoms, but also anorectal symptoms. And this overlap is quite characteristic for patients with functional gastrointestinal disorders in general. So this is also something that can be helpful for the doctor when he or she makes the diagnosis if the patient have symptoms from different parts of the gastrointestinal tract. That's actually points in the direction of a functional gastrointestinal disorder. But this is also important because, of course, this puts a lot of burden on the patient when it comes to symptoms, having symptoms from different parts of the gastrointestinal tract. And patients with a lot of overlap also have more symptoms outside the gastrointestinal tract, what we call non-gastrointestinal somatic symptoms, which is more common in these patients with a lot of symptoms from different parts of the GI tract. But also these patients with overlap also have more healthcare use. They have undergone surgery more frequently, sometimes unnecessary surgery. These patients also take more medications, and they visit their doctor more frequently. And it, of course, affects their quality of life in a negative direction. So this overlap is important both for the symptoms, because for the patient, because of course all these symptoms put a lot of burden on the patient, but also from a societal point of view, because of course this is driving healthcare use and then of course costs money for the society. I told you on the previous slide that having symptoms outside the gastrointestinal tract is common among patients with functional gastrointestinal disorders in general, functional bowel disorders, and IBS in particular, which is the topic of the discussion today. And on this slide, I've listed some of the non-GI symptoms or syndromes that are more commonly seen in patients with functional gastrointestinal disorders. You see fibromyalgia here, you see chronic headache, migraine headache, chronic pelvic pain and other gynecological symptoms, chronic fatigue syndrome, temporomandibular joint disorder, interstitial cystitis, and also various psychological problems that are more commonly seen in patients with functional bowel disorders and IBS. But importantly, these symptoms are not present in all patients with IBS, but it is more common that the patients with IBS report these symptoms than other people in the general population. So this is also something that the doctor can use to make a diagnosis of a functional gastrointestinal disorder, because if the patient also has symptoms outside the gastrointestinal tract, it is more likely that it is actually IBS or another functional gastrointestinal disorder. Now we will move on a little bit to the management or the approach to patients with IBS in general, but also this multi-component approach that I will talk about is also valid for other patients with functional gastrointestinal disorders, and I would say it's also relevant for all patients that seek healthcare for gastrointestinal and other symptoms. The basis for the approach to patient, for having a good relationship with your patients, of course, to establish this what you call physician-patient relationship early on in the management of the patients. And this is key for being successful when managing patients with IBS, and also for, of course, for managing patients in general. Of course, we should focus on the gastrointestinal symptoms, but we should also assess the general medical history, assess personality, family, because we all know that factors outside, not particularly only related to gastrointestinal symptom, but general factors can, of course, influence symptom perception and how the outcome of symptoms are. We should, of course, assess the quality of life and how these symptoms affect your daily functioning, because this will definitely influence how we manage the symptoms. We should take psychological or psychosocial factors into account, because I guess we all know that these factors can influence bodily symptoms in a substantial way, and therefore it's important to address these symptoms together with addressing the gastrointestinal symptoms. We should perform some appropriate testing, and we should confirm the diagnosis and make a confident diagnosis. That's really important to do that, and we should give the patient the name of the diagnosis. Many patients only hear what they do not have, but they don't get a proper diagnosis. So I think making a confident IBS diagnosis is a key to be successful in the management of patients with IBS. Then we should put a lot of effort into explanation, reassurance, which I will come back to, and then initiate treatment. But I would argue that the treatment starts early on, already when you establish your physician-patient relationship, which is key to the success of the management. So here you see a general treatment and symptom management principle figure, how you can actually manage patients with IBS in what you can call a stepwise approach, where you start off with making a confident diagnosis, then you move on to explanation, reassurance, and some education. You give some advice on diet, lifestyle, and how to avoid different symptom triggers that have appeared during the medical history taking. You can thereafter initiate pharmacological treatment based on symptom severity and pattern. I will come back to that. And there are specific ways to treat the more severe and refractory symptoms, which I also will come back to. But as I said already, the basis for this is to establish an optimal physician-patient relationship and to use what we call person-centered care, when the patient's agenda or view should be the focus of the management. And this is very important in general when we manage patients in the healthcare system. And this is another way of showing this, what you can call stepwise approach to IBS management and treatment, where you can see how we can sequence the treatment based on the severity of the symptoms. So the more severe symptoms you have, the higher up in this pyramid you will end when it comes to treatment options. So the basis for all patients with IBS is to make a proper diagnosis, provide explanation, reassurance, discuss precipitating factors, lifestyle factors, and also assess symptom profile and severity, since this is key for diagnostic and therapeutic decisions later on. Most patients also receive some kind of dietary advice, and these can be simple for the majority of patients, but for some patients who have more severe symptoms, these can be more elaborate and you then require a dietitian. If that's not sufficient, we can move on to pharmacotherapy, which is directed towards the dominant symptom. If that's not sufficient, we can also add or move on to psychological treatment options. And finally, if all of these have failed or are not sufficient, we can use what we can call a multidisciplinary approach. And I will come back to all of these different steps in the stepwise approach in a sequential fashion during my presentation. So we will start now first with the basis, which is diagnosis, explanation, reassurance, and so forth. We discussed that a little bit already, but I would like to stress again that this should be offered to all patients, regardless of the severity of their symptoms, because this is the basis for being successful when it comes to management of patients with IBS. First, of course, you should make a safe diagnosis. And here this is a little bit of a technical slide, a little bit of a busy slide, but I will walk you through the slide sequentially. We've discussed already the diagnostic criteria, so you should make sure that the patient fulfill the diagnostic criteria for IBS. We've discussed also how we can use other clinical features when it comes to making a diagnosis of IBS being more likely. If you have overlapping GI symptoms and if you have overlapping non-GI symptoms, that makes a diagnosis of IBS more likely. It's also stated here that you should address alarm symptoms. That's the alarm symptoms that we should think about are blood in the stools, fever, symptoms at night, weight loss. If you have onset of your symptoms at a higher age, normally above the age of 50, this requires then more thorough investigations before you actually could make a diagnosis of IBS. And there you should try to exclude other more serious diseases from a medical point of view before you actually can make a diagnosis of IBS. Of course, physical examination should be done in the clinical setting, and for all patients, some routine laboratory tests are normally performed, checking for the presence of anemia, inflammation, and ruling out celiac disease. That's the basic that all patients should be offered when being evaluated for suspected IBS. There are other tests that you can consider, which are listed here: thyroid profile, etc. And this is these are more based on the decisions are made on an individual basis and not routinely done for all patients. And if you then move to the right on your screen, you can see if the patient has positive symptom-based diagnostic criteria for IBS, other clinical features that support the diagnosis, no alarm symptoms, and normal physical examination and laboratory tests, then you can immediately move to making an IBS diagnosis, focus on reassurance, explanation, and treat according to the predominant symptom. But on the left, if you have alarm features, you have more severe refractory symptoms, you may need to do further investigations and tests based on the predominant symptom, what type of alarm symptoms you have, and so forth, and then do more thorough investigations before you actually have to move into give the patient an IBS diagnosis. But in most cases, you can actually go as you follow the route on the right side of your screen, where you have typical symptoms, no alarm features, no abnormal lab tests, a normal physical examination, and then move quickly to the diagnosis and focus on the management rather than doing a lot of unnecessary investigations. As I said, explanation and reassurance is very important, and actually the basis for management for all patients with IBS. You should explain the underlying mechanisms for symptoms. You should encourage a positive attitude, but you should also give the patient realistic expectation. I normally say to patients that unfortunately we cannot cure IBS, but we can in most cases, actually improve the symptoms with our management. I also often try to discuss and inform that IBS is very prevalent, so you're not alone with your symptoms. It's something that we see, all doctors see quite frequently. It's written here that it has a benign clinical course. This means that if you have IBS, you're not at a higher risk for developing more severe diseases. You are not at an increased risk of developing cancer, for instance. And the IBS does not develop into some other diseases that are more medically severe. It's quite common that the symptoms wax and wane, that the intermittent symptoms are quite likely. Of course, it has variable impact on quality of life, but we know that symptoms of IBS are very disturbing and can influence quality of life and daily activities quite substantially. This explanation reassurance should be given at the visit with the doctor, but can also be given when in what we can call an IBS school, structured patient education. It can also be given through written information. So, but regardless of how it is made, this is very important that this is offered to all patients with IBS. The next step after this explanation, reassurance, discussion of lifestyle factors, precipitating factors, and so on, the next step is frequently to give some kind of dietary advice. This can be this can be done in different ways. The more simple dietary advice can be given by a doctor at the time of the visit to the doctor. For more elaborate dietary advice, you need to collaborate with a dietitian or a nutritionist in order to give this advice. So here is a list of some advice that we can give when it comes to changing the diet for patients with IBS. The first thing that we often do is to encourage them to have regular meals and to eat small frequent meals rather than large infrequent meals. Some patients also do well after reduction of fatty food. Coffee is a stimulus for the movements in the gastrointestinal tract, and can be deleterious for patients with diarrhea. Might be beneficial for patients with constipation, even though that has not been proven. But especially those who have a lot of loose, frequent stools should probably reduce their coffee intake. Sometimes it's the triggering of food intake, how food can trigger symptoms, might be related to psychological factors, and that can also be addressed when you discuss dietary advice. Some patients do well from reducing lactose and fructose, and also reduction of gas-producing foods, and this can be tested quite early on. When it comes to fiber, it's important to discuss the type of fiber and the dose of fiber. Some patients with IBS cannot tolerate high doses of fiber because they will then get gas-related symptoms, bloating, abdominal distension, and so forth. Most of the time, patients with IBS tolerate soluble fibers better than insoluble fibers. Soluble fibers are more present in vegetables and fruits. And if you should increase your fiber intake, probably that's the way to go for most patients. But you should be careful by increasing your fiber intake too much. There's a lot of focus now on eliminating wheat and wheat-containing products, and we may come back to that later on. Some patients do well on that. And then we, of course, had the now very popular low FODMAP diet. FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These are carbohydrates that pass unabsorbed through the small intestine, and then these carbohydrates reach the large intestine, and there they meet bacteria, which lead to fermentation and gas production, and also drags water into the gastrointestinal lumen. This then leads to distension of the bowel, and if you have a sensitive bowel, this can lead to symptoms. And this is actually how we think that we know how FODMAP can lead to symptoms. So this low FODMAP diet is about reducing foods that are rich in FODMAPs, and this is fruits, vegetables, different grains, and so forth, lactose products. And this is a quite complicated diet for which you need a dietitian to be successful. So these are some of the general features of dietary advice for IBS patients. And you start off with the more simple advice, and if this is not sufficient, you can move on to the more elaborate diets, for instance, the low FODMAP diet. And this is actually something that is shown on this slide, which is again a little bit complicated, but this is from a very nice recent publication from the British Dietetic Association, focusing on how dietary advice should be given to patients with IBS. And on the top left part of the slide, you see that the first line options when it comes to dietary advice, such as offering checking healthy eating, lifestyle, check for food intolerances, for instance, lactose, avoid the dietary triggers, reduce fatty food, etc., is given as these advice are given as a first line dietary advice option in parallel with the clinical evaluation that runs on the left. So this is what you offer first, and if that doesn't work, you can move on to the second line dietary advice option, which here is a low FODMAP diet. And you also see the three steps in a low FODMAP diet here: restriction phase, reintroduction phase, and the long-term management. The restriction phase is where you would restrict more or less all foods that are rich in FODMAPs. And then if that is successful, you try to reintroduce these foods step by step, and then you come up with a long-term solution, because you don't want to end up on a very restrictive low FODMAP diet in the long run. We don't think that is healthy for your gut in the long run. So therefore, you should also have the reintroduction phase and then some kind of long-term management. And that is done in collaboration with the dietitian. So here you see some of the general principles behind dietary advice for patients with IBS. If that doesn't work, normally we move into pharmacotherapy, targeting the dominant symptom. For instance, if you have the predominant constipation, diarrhea, gas, bloating, psychological factors, or pain, you choose different treatment option, and I will show you that on the coming slide. This is also a relatively busy slide, but this is a principle of how we actually deal with pharmacological treatment in patients with IBS today. As I said, we try to target the dominant symptom, diarrhea, pain, bloating, abdominal distension, or constipation. And as you see in the different boxes here, you see the different treatment options that can be used to target these different symptoms. So for instance, for diarrhea, the first line option here is loperamide, normally given at a relatively low dose, but on a regular basis. For instance, one pill in the morning and one in the evening, and then you try to modulate the dose based on the symptom response when it comes to diarrhea. So when you have a firmer, less frequent stools, you can actually stop at that dose. The first line option for constipation is often to increase the fiber dose and use some laxatives. For pain predominant IBS, the first line option is antispasmodics, which are thought to reduce what you can think about as cramps in the gastrointestinal tracts, to reduce pain through that mechanism. Quite frequently we move on to the second line option here quite quickly, which are low dose antidepressants, for instance tricyclic antidepressants, which are then given at a low dose below the dose that are used to treat depression. So it actually these low dose tricyclic antidepressants, for instance amitriptyline, there we don't think that will treat depression, but rather treat the pain and have their effect within the gut rather than only in the brain. On the right side, you see what we can offer when we have more refractory, more severe symptoms, where you actually use different kind of antidepressants, but also what is called psychotropics. But what's important here is that we don't only target the psychological symptoms that are there, and actually we don't even have to have psychological treatment, psychological problems in order to use these drugs, because we know that these drugs also modulate nerves outside the brain, and we actually call these drugs neuromodulators, which I will show you on the next slide. I forgot to mention some of the other alternatives for targeting the different symptoms in IBS, which you can see also in these boxes. These are the newer drugs that have been made available during the last couple of years. And as you can see, these treatment options target different symptoms. They can actually improve more than one of the symptoms, but still these are quite new drugs and they are more expensive, so we recommend them at this stage to be second line treatment options if the first line options don't fail. So now let's move on to what I told you about regarding the use of psychotropics, antidepressants, or as we prefer to call them today, neuromodulators. These are of course known as antidepressants or psychotropics, and can be used to treat symptoms like depression, anxiety, and other psychological problems. But when we use these drugs for patients with functional gastrointestinal disorders, we actually try to modulate nerve function also outside the brain in order to modulate or reduce gastrointestinal symptoms. And that is not only, as I said, targeting depression and other psychological symptoms, but also targeting gastrointestinal symptoms. Here you see the main drugs, the class of drugs that we use. As I said, for pain, the first line option is often this tricyclic antidepressant, but also here what you call the SNRIs, that is the drugs that affects both serotonin and noradrenaline, are also effective in treating pain. The SSRIs, that are drugs that are targeting serotonin, are effective for IBS, especially when there is also comorbid anxiety and other psychological symptoms at the same time. On the bottom part of this slide, you see that we have written augmentation, which is actually when we can combine these different neuromodulators and also combine these neuromodulators with other psychological treatment option in order to augment or improve or enhance the effect on the symptoms. And by combining different drugs, you can actually have a lower dose of each of the drugs, and then you can reduce the risk of having side effects. So this is something that we use quite frequently. But of course, you should be, if you use that as a doctor, you should of course be familiar with these drugs and how they can interact. But this is something that is more and more frequently used today to treat more severe treatment refractory symptoms. Psychological treatment options are also useful and have proven to be beneficial for patients with IBS and or other functional gastrointestinal symptoms. You see here listed CBT, which stands for cognitive behavioral therapy, hypnotherapy, and also psychotherapy. And all of these have actually been proven to be beneficial for treating gastrointestinal symptoms in patients with IBS. So it's not only to treat the psychological symptoms, but also to treat, predominantly to treat gastrointestinal symptoms. And for that, there are several trials that have been published. And here is a summary from a meta-analysis where all these trials were pooled together to see the effect of these different treatment options. And what this slide shows is that cognitive behavioral therapy, hypnotherapy, and dynamic psychotherapy are all effective in treating gastrointestinal symptoms in patients with IBS. Relaxation therapy didn't quite make it, but there is a clear trend that this is also favorable for patients with IBS. The problem here is the availability. In many countries, it's the number of behavioral therapists who are available to treat patients with IBS and other functional disorders are limited. So that's actually one of the big limitations to the treatment option. But they are effective, just as effective as many of the drugs that we use today. And then if you come to the top of the pyramid, you have the patients who have severe, often treatment refractory symptoms, who have failed many of the other treatment options that I've talked about already. And here we advocate what we can call a multidisciplinary approach, where we work together, several different disciplines within medicine, gastroenterologists, pain specialists, psychologists, psychiatrists, nurse specialists, and a lot of support functions that should be used also here. So here we need to work together to improve the lives of these patients who have really severe symptoms. The management here should be patient-centered, and again, physician continuity and the good physician-patient relationship is key to manage these patients with severe therapy refractory symptoms. So this is my summary slide before we move on to the Q&A session. I've told you that it's important to have a multi-component approach when you manage patients with IBS, not only focusing on symptoms, but also on other factors that we discussed early on. And to establish a very good physician-patient relationship is a key to being successful here. Explanation and reassurance should be offered to all patients with IBS, regardless of symptom type and symptom profile. And this actually forms the basis for management of IBS. We should have a cost-effective diagnostic approach. For the majority of patients with IBS, there is no need for a lot of investigations. Some simple blood work is most of the time sufficient to make a safe diagnosis of IBS, and this is important when you think about the management approach to patients with IBS in general. I said several times during my presentation that a good physician-patient relationship is key. I stress that again. Dietary advice, lifestyle advice should be offered early on to patients with IBS, but if you embark on more difficult or elaborate diets, you should do that together with a nutritionist, dietitian, in order to have nutritional adequacy and when you use your dietary advice. Pharmacotherapy we use quite frequently. The drugs that we use try to target the dominant symptoms, as we discussed already. Psychological treatment options are effective and not only targeting psychological symptoms, but primarily also the gastrointestinal symptoms can improve as well. And we should work together within the healthcare sector to really improve the symptoms. We should work in a multidisciplinary way, not perhaps not only for the most severe patients, but also for the moderate and sometimes also the mild cases. So with this, we've come to the end of the presentation. We now have time for questions. So now I would like to invite Stephanie Twist from ANMS, who will ask some of the questions that have come in from you, either before the session today or during the session. We now will transition from slides to live video. So Stephanie, do we have any questions?
Yes, we've actually had a few questions come in. The first one is, can IBS be an early warning sign for gastroparesis?
The symptoms of IBS, which are abdominal pain and abnormal bowel habits, are not typical for gastroparesis. But of course, as I said, there can be an overlap with upper GI symptoms that are more typical for gastroparesis, such as nausea, vomiting, and postprandial fullness, and more upper GI symptoms. So there can be an overlap, but I wouldn't call IBS a part. It's not part of the gastroparesis and not really an early warning sign of gastroparesis.
So one of the other questions we received before we had this video to Facebook Live today is IBS-D just a diagnosis they give you if they can't find any other reason for, say, diarrhea?
IBS is not a diagnosis of exclusion a diagnosis that you make when you have exclude all other causes. But this question, the one who's posing this question is partly right, because if the patients with diarrhea predominance, there we are a little bit more careful before we actually make the diagnosis of IBS, because there we have more differential diagnosis. You should at least with blood test rule out inflammatory bowel disease, but also microscopic colitis, bile acid malabsorption, so be considered before you make a diagnosis of diarrhea predominant IBS. But with a typical history and with some limited blood tests, and potentially in patients with more severe diarrhea, also colonoscopy with biopsies, a diagnosis of IBS-D can be made quite early on without the need of many investigations.
So one of the questions that came up on Facebook Live was, what are your thoughts on ketofen for visceral hypersensitivity in IBS?
I don't think that's part of the what is being used yet, but there are some promising trials that might show that this is something that we can use in the future, but we do not include it in our recommendations today. But I think we need to await those clinical trials before that can be recommended, actually.
All right. Is a colonoscopy necessary to have an IBS diagnosis? And if not, which patients should this be performed on?
I've alluded to that question already, and a colonoscopy is not necessary to make a diagnosis of IBS. We advocate colonoscopies for patients with severe diarrhea to rule out inflammatory bowel disease and microscopic colitis. And of course, also if you have warning signs, alarm symptoms such as blood in the stools, etc., because then you really need to do a colonoscopy to rule out other diagnoses. But in general, a colonoscopy is not needed for the majority of patients with IBS.
All right, we had another question come in. What do you think of over-the-counter products such as IBGuard?
Yeah, many of the over-the-counter products that are available in the US and in other parts of the world have actually shown some benefit. So they can be used, and most of them are safe as well to use. So I advocate my patients to try many of the different over-the-counter products. And just because they are over-the-counter doesn't mean that they are not effective. So yes, I think that they are useful in treating patients with IBS in general.
All right. Is a gluten-free diet effective for IBS?
Uh, the short answer to that is no, not for all patients with IBS. But we also know that many patients with IBS do better on a wheat-free diet. We don't really know why that is. There are some hypotheses that this is more related to again to this FODMAP concept, because wheat is rich in, or wheat are rich in wheat is rich in fructans, and fructans are FODMAPs, and by reducing wheat or eliminating wheat, you actually reduce the FODMAP content. So some patients do go on a wheat-free or wheat-reduced diet, but definitely not all of them. And we don't really know if it's gluten or, as I said, FODMAPs or other parts of gluten that are more relevant for the symptom generation. So um, some of my patients try a wheat-free diet or a wheat-reduced diet and do well on that, and then they continue with that with good results. But not all patients do well on a wheat-free or wheat-reduced diet.
All right. One that came in from Facebook Live is, are there any recommendations for IBS-C with a dual diagnosis of gastroparesis?
Well, then you should, of course, IBS-C and gastroparesis. Then you often think about drugs that can stimulate motility. And in Europe, we have a drug, and I think you also have it here in the US now or soon, which is called prucalopride, which is actually for constipation. But there are also trials now demonstrated that it actually can accelerate gastric emptying and then also benefit patients with gastroparesis symptoms. So there are some treatment options that can be used to treat both the constipation and the gastroparesis. And it, of course, it's logical then to think about factors or drugs or treatment options that stimulate motility, enhance motility, that makes things empty from the stomach quicker and also move through the colon quicker. And I gave you an example of prucalopride, which is a drug for constipation, where there's also some evidence suggesting that it affects upper GI symptoms as well.
All right. One that came in before the talk that said, if you have ulcerative colitis and you continue to have symptoms similar to what you had talked about earlier today, even when there is no inflammation, can this still be IBS?
That's a very good question, and there is a large proportion of, or a proportion of the patients with inflammatory bowel disease who use anti-inflammatory treatment options when they do a colonoscopy or when they take blood tests. There is no signs of active inflammation, but they still have symptoms compatible with IBS. You can argue whether that patient has IBS or whether he or she has IBS-like symptoms. Regardless of that, I think you can, if you have the inflammation under control but still active symptoms, you actually can use some of the treatment principles that we use for IBS also for these patients to treat their symptoms. But of course, you need first to make sure that you really have the inflammation under control. That's, of course, the first line approach for patients with inflammatory bowel disease. But many of these patients actually have ongoing symptoms that resembles IBS even when the inflammation is under control. And then you can use treatment approaches that we use also for pure IBS patients.
All right. What are some typical causes of fat malabsorption and how can it be investigated?
Well, fat malabsorption is mainly related to pancreatic insufficiency. There are some tests for that. Most of the tests for fat malabsorption are not very good and not very valid, and that's a problem to really diagnose that. But if you have true fat malabsorption, then the ideas or the thoughts of the doctors actually lead to some pancreatic disorders. But most of the time when you actually think that you have fat malabsorption, you do not have fat malabsorption. And many of the tests that we use today are actually quite poor when it comes to diagnose fat malabsorption in the clinic.
All right. And so someone had asked, what are your thoughts on fermented foods to help repopulate beneficial gut bacteria?
Yeah, that's popular in certain areas of the world, and some patients claim that it helps, and I think it does help for some patients. It might also cause symptoms in other patients if you use fermented food. Actually, some of my patients say that if they eat fermented food, they have more severe symptoms. But I mean, if you think that your symptoms are better off by using fermented food, I don't see any harm in doing that. There are no good trials really showing that this is the case, but I don't advise against using that to my patients who actually are doing well on fermented foods. But as I said, some of my patients also said I cannot tolerate these fermented foods because then I have a lot of gastrointestinal symptoms. So it seems to be you can use this advice on an individual basis and try it and see where it works for you. In general, I think when it comes to dietary advice, we need to personalize and individualize the dietary advice in the future. But we don't have sufficient knowledge really to do that and know how we should do it for an individual patient. That is, what individual advice we should give to an individual patient. But that is something I hope can be more obvious for us in the future. Perhaps we can know more about the gut microbiota in the individual patient, and based on that knowledge, individualize dietary advice. But we are not there yet in the clinic.
That's actually a good tangent to one of the questions that came in earlier. What dietary guidelines are currently being recommended and why?
Yeah, I think that's a good question, and we partly discussed it already. But I think for the majority of patients, we should try the first line treatment options that we discussed. Smaller, frequent meals. Think about fat reduction. Try to find dietary triggers. Potentially see whether lactose and fructose reduction may be good for the patient. Think about fiber and type of fiber and dose of fiber. And if that doesn't work, then we can move on to try a low FODMAP diet. But then, as I said, we need a dietitian, nutritionist to help the patient with that. So there are some current guidelines how to use dietary advice for patients with IBS. But hopefully in the future we'll be able to individualize these treatment advice better to our patients. We also talked a little bit about gluten-free diet. The jury is still out there how effective it is and whether it's related to gluten in wheat or whether it's related to intake of FODMAP or FODMAP content within the wheat, that is fructans.
All right, another question is, what are your thoughts in general on rifaximin?
I read the studies on rifaximin. It is not approved for the treatment of IBS in Sweden. So I don't have a large experience with rifaximin. It's definitely not something that helps all IBS patients, but it may be beneficial in a subset of IBS patients. And the retreatment trial that was performed here in the US demonstrated that it was safe to use up to 3 times or during 3 periods. So that's what I can say. I can say what I know from the literature. My American colleagues have more experience, of course, because it's approved here in the US for non-constipated IBS. And I know that many of my colleagues use it. And if it is effective, it seems to be safe. But as I said, I don't have much experience myself.
All right. Is IBS also present in older individuals or only when you're young?
That's also a good question. I mean, this is something that has been known for a while, that these symptoms of functional gastrointestinal disorders such as IBS tend to decrease with increasing age, but it doesn't disappear when you grow older. There are maybe a little bit of shift of symptoms when you get older. Constipation seems to dominate more when you're older, and also fecal incontinence is another symptom that is more frequent in the elderly than in the younger. But whereas IBS seems to decrease with increasing age. We don't know the reason for this, but what is important is that it doesn't disappear from the population in older age, but it decreases in the older population compared to younger individuals.
So this one came in again before you had started. If a person starts on a neuromodulator, for how long should they take it?
There is no clear guidance from the literature how long you should continue with the neuromodulate, but we actually think that it should continue at least for 6 months. Most of my patients continue at least a year for a neuromodulator, because we think that the beneficial effect can continue to kick in for a long period of time. And actually, there's some evidence that it actually can modulate the nerves so that they stay less sensitive also when you stop the drug if you continue for a longer period of time. Most guidelines say that you should treat at least for 6 months, sometimes up to 1 more year, and many of my patients do not want to get off these drugs because their symptoms has been so well controlled with them, so they continue for even longer period of times. But it's not for short-term use. That's something that we can say.
All right. What are your thoughts on the findings of small bowel fungal overgrowth in some patients with IBS?
These are relatively new findings coming from the US. We have not looked at that in our unit, and I think it's interesting, but I don't think that this is sufficiently validated to be used in the clinical setting today. We need more studies and also from different groups to really show that this is of importance for patients with IBS. But I definitely think this is these are interesting findings that are definitely worth exploring more. And there are now also studies that have looked at the composition of fungi in the large intestine, and there seems to be differences in the fungal composition in the large intestine in IBS patients, whereas compared to control, because all of us, we have fungi in the GI tract, and they should be there just like the bacteria. We should not get rid of all the fungi. They should be there, but they should be in balance, just like the bacteria in the gut. They should be in balance. So I think we need more investigations before we really know how relevant these findings are. But as I said, very interesting findings.
All right. Is IBS only present in Western countries, or does it also exist in other parts of the world?
I get that question quite frequently, and sometimes we have the impression that, I mean, when we read magazines, popular journals, and so forth, that this is a Western disease, Western disorder, but this is not the case. We have evidence from several epidemiological studies, including now the current Rome Global Epidemiology Study, that these disorders are frequent also in non-Western countries. So this is something that is present all over the globe and not unique to Western countries. Okay, so we don't have any more questions, but I thank you for posing all of these questions. It was fun to chat with you, even though I haven't seen you. It's been a pleasure giving you this presentation, and I hope you have some interesting thoughts of this, and I hope that I provided with some insight into how to manage patients with IBS. And with that, I would like to thank you for listening, and hope to see you somewhere soon again. Thank you.